Great. Can I start with you, Antonella, and sort of some key principles that underpin cancer control plans, some key principles around patients and putting them at the center, I suppose.
So thank you, Vivek. So it's I represent patients as I speak on behalf of Cancer Patients Europe, and of course for us it is of fundamental importance to have patients involved in the development of national cancer care plans from the very beginning, from the design stage to the implementation and monitoring on the impact. And this is because we believe that patients can bring a unique perspective. And what is fundamental for us is that the cancer plans address inequities, which is a fundamental issue, and address inequities at European level, as we work at European level, but also in the member states. So inequity for us is a key principle, but then also the national cancer plans are a good tool to gather data, fundamental data on the implementation of the plans, so that they can showcase the good results of the plans, but also they can provide benchmarks to compare different plans in different member states. And it is also important for us that the national cancer plans so embed those data, they are fundamentally centered around the patient involvement.
Thank you. So let's build on that implementation. So the bridging from the plans to actually delivering and enabling good diagnostics and treatment and implementing plans. What are the key principles from a global perspective, Carrie, that need to be put in place?
Yeah, so from UICC's perspective, and we're in formal relations with the WHO, the World Health Organization. Mm-hmm. So we're very closely on this particular aspect, which is the rollout of national cancer control plans around the world. It's really important that patients, individual patients with lived experience, are included in the process of developing and maybe the implementation of the plan. But as importantly is patient groups. Because patient groups in most countries are closer to the patient community than indeed the government is. So we would argue that patient groups should be included in the development and implementation of plans. In fact, in many countries, it's civil society which takes forward a large aspect of the cancer control plan in the country. That could be, for example, even organising and running the screening programs or running support desks or things like that. And I was actually inspired by Dorothy Keefe from the Australian government, Cancer Australia, a couple of weeks ago. She spoke about their current plan, which they launched on July the 1st, I think it was. You were there. It was July 1st, wasn't it? And she talked beautifully about how they had gone through a process of bringing in all sectors into the thinking and development of the plan, including the private sector. Mm. And that the output from that plan, which was a series of actions to be taken, including, thankfully, lung cancer screening, would be delegated out or sort of handed over to other organizations to take forward. That's quite a unique model, and I'm really interested to see how that goes forward. But what it does say, and it's said in many UN high-level meetings, says we need a whole-of-society approach. Well, that sort of that emboldens a whole of a society approach, that each component party sector has a responsibility to ensure that the cancer control plan is implemented. And then also the coordinating body will be the government itself. So yes, important for patient voice in the development and maybe implementation, but there are other sectors, particularly patient groups, which I think can play a fundamental role in that development and implementation.
Right, okay. Mark, I know one of your areas of passion and study is around inequalities, which Antonella alluded to. And I suppose related to this point, so what the broad question is examining and reducing inequalities in diagnosis and treatment, and we can focus particularly on Europe as this is the European series. But also maybe related to that is the fact that patient groups may be differentially vocal or skilled in different areas, and how how do you manage that particular challenge with equity? But there's a whole set of questions.
Yeah, no problem at all. Yeah, I mean, I am very passionate about equity and inequalities. For the last 12 years, I've really worked in that area in some aspect or another, and that led initially to us launching the European Cancer Patient Bill of Rights in the European Parliament on World Cancer Day in 2014. And what was critical to that was the fact that it was co-created. And back to what Antonella said at the start, and when I say co-created, I don't mean just collaboration, I mean co-created, actually sitting down together. And I think that's really important. And one of the lessons we learned actually during that overall process, I can remember at one stage, the health professionals were saying, oh yeah, we've got it now, let's go and do it. And I said, no, I don't think we have actually got it, because I don't think we've listened enough, and I don't think we've nuanced out exactly what you've said for different situations, different countries, etc. So we actually I can remember holding a patient forum, the third one we had, but an extra one in Dublin, because we felt we hadn't bottomed out exactly so that everybody was getting the right sort of aspect to it. And one of the things I believe a lot is in fair value, and that should be fair value for everybody who's participating in whatever the initiative is. But it's particularly important that we're making sure that the patient first, the health service, if we're talking about research, the researcher, and the private industry as well, because we're all working together. Cancer is our common enemy, and that's what we're trying to do. You're looking at it against it. I mean, I think one of the big challenges we face is moving from plans to implementation. And it's a little bit like, I use the analogy sometimes. I'm not a great cook, okay, so don't quote me on this. But it's a little bit how you make a souffle without an oven. So if you don't have the souffle and put the souffle in the oven, you're not going to have a cake. You're going to have a mess that looks awful and probably tastes awful as well. So you need to be able to do both parts. The innovation part that gets you to a stage to say, this is how we want to deliver something, but then the implementation. And I think, as we discussed yesterday in some of the sessions, implementation is not easy. And sometimes we need to think about, how do we facilitate implementation? How do we do implementation science? In general, we funded very little, and it's something that's critical. And it's probably critical to Europe, because Europe is very good at innovation, but not so good at implementation. And it's a little bit like, saying that, we're very good at breakthroughs, but we're not so good at follow through. And in order to do that, I think we need to make sure that what we're trying to do isn't trying to necessarily boil the ocean. Are there key things that we can get into the plan that are actually activated first? You can't do everything at the same time, but it needs to be a logical progression. So a good example is looking at early diagnosis. Early diagnosis is great, but not if we don't have the capacity to then treat the patients early. So it needs to be linked to each other. And we highlighted yesterday the importance of survivors and survivorship and that living beyond cancer. And I think increasingly we're going to see that more often in relation to, living well after cancer, reintegrating into the society. I mean, one of the things we did was through the European Cancer Organization was the European Code of Cancer Practice, again, co-created between patients and patient advocates and health professionals. But it's interesting, codes 7, 8, 9, and 10. So these are the 10 things a cancer patient or a citizen, actually a European citizen, should expect from their health system in the context of cancer. 7, 8, 9, and 10 are all related to rehabilitation, reintegration into society, quality of life. So there's 4 to 10 are actually talking about that survivorship period, that living beyond cancer period. So we need to be really thinking about that.
Okay, thank you. And Jennifer, I think I'm building on those previous comments. I guess the biotechnology industry in general has to, I suppose, shift from simply inventing. Simply is, sorry, that's that's making it
17 years.
But what inventing biotechnologies, but actually looking to how they can be implemented, because that's in everyone's interest, including the industry's own. So, and you talked about, Carrie, about how the engagement with private industry is working in some instances. So how do you see that shift, and how do you play into that, I suppose?
Yeah, thanks for the question. So at Pfizer, our purpose is to deliver breakthroughs that change patients' lives. And we're really driven by the desire to accelerate the advancement of treatments to help oncology patients in particular live better and longer lives. And, reflecting on the importance of multi-stakeholder engagement to shape national cancer plans, I would say there are probably 3 key areas where the private sector, and in particular, companies like Pfizer, are very engaged in shaping. One would be with respect to knowledge sharing. So we've been very engaged in helping to inform evidence-based strategies within national cancer plans. For example, helping to share clinical trial insights, real-world data and evidence, as well as contributing to calls for evidence from countries and from member states. So one example recently where we've been able to contribute is to the UK's national consultation on their national cancer plan, where we really underscored in our submission the importance of valuation, adoption, and uptake of cancer innovation, and frankly, how important that is to the ability for people living with cancer to have access to standard of care for detection, diagnosis, and treatment. And I would note that, equally important to supporting those plans is our policies that support innovation in general, so that we can ensure that we can bring the latest breakthroughs in science to them. I would say a second area where we're really engaging from the private sector point of view to shape national cancer control plans is with respect to capacity building to address health disparities and disparities in care. And, we all know that cancer can affect anyone at any place at any time. It doesn't discriminate, depending on where you live. And frankly, that presents an opportunity, again, for stakeholders to come together and really, on the private sector side as Pfizer, we are helping to support community in education programs. We are, for example, partnering with our Pfizer Foundation is partnering with NGOs like Partners in Health to help strengthen national capacity for breast cancer screening in countries like Rwanda. We're helping to strengthen electronic medical records, and we're also helping to strengthen the ability to access some of the treatments. And then finally, or thirdly, one area that I'll flag in closing in terms of coordination is really just the importance of maintaining open dialogue across a broad range of stakeholders to really share best practices in terms of what is working, how we measure success in terms of the evolution of the plans themselves, but also co-ideating and co-creating solutions. So it's been really great to partner with UICC, with EPF, with many other organizations over the past year plus, as we're thinking, I would say, in a more focused way about how do we really work to strengthen the ability of governments to deliver on improving cancer care.
Mm-hmm. Yeah, Mark.
Just one of the things that Jennifer brought up in terms of consultation on the National Cancer Plan for England, and Pat in the audience might want to comment on this as well. One of the things you have to do, of course, is to get them to that stage that they've agreed to actually implement a cancer plan. And certainly one of the things we found really useful was actually publishing articles in Lancet Oncology as opinion pieces, which actually, amazingly, government offices do actually read the Lancet Oncology, which you mightn't think they do, but they do. So we had a planned series of, I think, 3, 4 that we produced that all highlighted particular areas. So we're all saying we want a cancer plan, but it wasn't just shouting and roaring and saying we need a cancer plan, we need a cancer plan. We're saying this is why we need it, this is what you could do. We even presented them with a sort of a draft cancer plan that they could look at. We're planning on another one now that it's been agreed in relation to that. So it is important, that sort of ability to influence and bringing the sector together to actually influence the government to make a decision, because certainly the mood music before the current administration came into place was not to produce a specialist cancer plan. So we had to work very hard. So it is just important to remember, and also obviously publishing in the likes of The Guardian, etc., helped us as well. So that sort of pressure that you sometimes need to exert, backed by data. So that's really important, that you back it with evidence that shows this is why. And we were able to provide that evidence and provide it to the House of Commons Select Committee.
Sure. Okay.
Yeah, just to build on that, and UICC has been monitoring cancer control plans for quite a while. And for those who are interested in cancer control plans, if you want a good night's sleep, go to iccp.org/cancer portal, which is the International Cancer Control Planners portal. And on there, every single national cancer control plan is logged, and the historical ones as well. And you can search it and find out what country, you can look at each country's plans. What we do is every 3-4 years, we analyze where we are with regard to cancer control plans. And we've seen progressively over the last 10 years, an increase in the number of plans around the world. So countries covered by a plan, which is great. UK's been quite the exception recently, I must say. Yeah. But what we have, and also the content has improved significantly. It doesn't include radiotherapy or necessarily AMR, but it's improved in terms of covering the full cancer continuum from risk factors through to palliative care and supportive care. Where we still see weakness is on the funding of the plan. Yeah. There are only 22%, I think, of plans currently available in the world which actually talk about the funding that's going to be put in place for that plan to happen. Now, we all know, I'm an ex-banker, that you can't do much without money. So I pity a lot of the health ministers who write beautifully crafted plans, and then the finance minister doesn't actually give any money or sufficient money for that. So I think certainly for the next decade, I think one of our key objectives has got to be to convince not just the health minister, you need a great plan, but to convince the finance minister that this is an investment in the wealth and health of the country in the future. It's not just about cancer. It's got to be about investing into the economic wealth of the country. So the economic basis of a plan, I don't think has been well articulated in the past, and something that maybe we need to work on in the future.
Antonella.
Yeah. And I think, Kerry, to build on this, is the challenge is really now looking at monitoring the implementation. So one thing is to look at the number of countries that have developed a plan, which is a nice, piece of paper. That is out there, and as you said, only 22% of those plans are funded. So we need to look at the implementation, because now it's over a decade that we have started to see nice cancer plans on the table. And I think that when it comes to the implementation, we also need to look at how those cancer plans have evolved since they started. Are they following up with the innovation, for instance? Because this is another important issue that we need to look at. What I mean by that is now, compared to 20, but also to 10 years ago, we have a completely different approach to treatment and to diagnostics. And is this reflected into the new cancer plans? Are we looking into that? This is something that is very important for us, because unfortunately, in the implementation, we see too often that innovation into treatment doesn't go hand in hand with the innovation into diagnostics in terms of access to patients. So what is the point of having a precision oncology treatment, a personalized treatment available and reimbursed, when the diagnostic is not available and reimbursed to patients? And unfortunately, this is the case in too many member states at the moment. And it would be good to see this mismatch, in a way, evidenced into the plan, because this would showcase or put the reality in front of the policymakers, which probably not always realize of this mismatch. And what is very important to us is that the cancer plan follows the innovation, rather than the innovation slowing down or stopping because the cancer plan or because the health system is not ready to follow the innovation.
I have a follow-up question on that, but yeah, Mark, you want to...
Just very quickly, just for what both Kerry and Antonella said, one of the things we did in the International Cancer Benchmarking Partnership was develop a policy scorecard to address exactly those points. That, does it make sense? Does one plan follow to the next? Are there things that were missing in the first plan that came in the second plan? Is it financed? And they all add to that score. So if you're up near the top, like some of the Australian states were, and Canada, for example, and some of the Scandinavian countries, it's because you've hit all those sort of targets. If you're down at the bottom, like most of the UK nations, it's because you haven't hit those targets. And unfortunately, you need to be brutal sometimes to provide the evidence that shows that. But I think it's really important, as you said, and we need to continue to measure to see, are we actually having consistency? Because it's the consistency. If somebody has one cancer policy and then doesn't have another cancer policy for 15 years, that's not consistent. And if they're not using one to sort of address one issue and then, the other is another issue. So I think that's really important.
Jennifer, is anything else?
Yeah, I think I really want to build on the point you made, Antonella, about, are health systems ready to absorb the innovation that manufacturers are ready to bring to the table? And I think, a key part of that is ensuring that you have the policies that are supportive of that innovation, but also, frankly, that that there's a broader recognition of the value of investing in health in general, and the longer term benefits that can reap. We supported a study earlier this year across 144 countries that found that countries that are implementing national cancer control plans do generally see better health outcomes in cancer. And I think that's really compelling in terms of not only decreased mortality, but also increased survival, to show that, there is real value in taking the time and really focusing and dedicating the resources from a financial point of view, to really execute and make sure that, what we say we're committed to doing is actually happening.
But can I just say, I think you're right. We need health systems that are robust enough to receive new innovation. But as Pat articulated beautifully earlier, most countries don't have radiotherapy. So we've got to be careful. There's got to be a balance, I think, because there are stuff out there's medicines out there that are 25 years old being used in the UK and Europe, aren't available in Africa. And 25 years old. There's common practices which are being applied, like diagnostics. And diagnostics in most low middle income countries is out of pocket.
Yeah.
That stops people even getting to treatment. Even if treatment is available, they can't afford it because it puts the family in financial crisis. Just the diagnostic. So there's a balancing act here, isn't there? Because yes, we all want the latest innovation to come through, but clearly we want what has been working for many, many years to be available to all.
And to build on what Jennifer mentioned about the fact that where national cancer plans are, there are better health outcomes. Another important thing that we advocate for is making sure that the national cancer plans embed indicators, clear indicators that can be measured to see if the plan is implemented, if it is successful or not. And to that extent, for instance, we believe that a way to build up on Europe's beating cancer plan and the sustainability of the plans is to make sure that is to use an existing mechanism, such as the European semester on health, implementing the European semester on health, which already exists. So we do not have to invent or create any new mechanism. So we have a mechanism that is used essentially by member states on economic indicators. They started to look at health indicators during COVID. But then, of course, now COVID is gone, so no much interest in health anymore. So what we are saying, why don't we boost the European semester on health with a pilot on cancer, building on the experience of Europe's beating cancer plan and the cancer mission, using the national cancer plans as a way to continue gathering data that are already there. They just need to be identified and used and discussed within the European semester. So with I mean, very little or no additional cost because the system is already there, but just looking at the data, raises awareness on the challenges, mismatches, gaps that are in the system, and will force, in a way, will put some pressure on policymakers in order to address those gaps if the numbers are put in front of them.
So I'm going to ask a real basic primary school question about cancer control plans. We're talking about how we improve outcomes through better diagnosis and treatment, defined broadly. What is it that a cancer control plan, a good cancer control plan, brings that enables that? You know, what are the key elements that are brought by this piece of paper that is then implemented, ideally? How does that enable it? So can you walk us through what it contains that actually leads to the better diagnosis and treatment?
I could maybe start with the Northern Ireland example. Serve as a good example of. So take you back to the 1990s in Northern Ireland. Very challenging time to be in Northern Ireland from a political point of view, but also if you had cancer. So essentially we had the poorest outcomes in the United Kingdom for pretty much any cancer you could talk about. 1996, the chief medical officer at the time, Etta Campbell, introduced a report. But the report was not just a report that sat on the shelf. It was actually a report that said, I want a cancer plan. So this was the first national cancer plan for Northern Ireland. And to show how bad the situation was, for surgery, 64% of surgeons only did 10 breast cancer operations or less. So that means essentially they were not breast cancer surgeons because they were doing far too low in terms of actually keeping their competency up. And there was really no research, no clinical trials. So what she did was she sort of enabled then a process by which a group came together, took the document and said, okay, 4 things we need to do here. First of all, we need to collect data and evidence. So more enabling the National Cancer Registry, which interestingly enough, the Northern Ireland Cancer Registry was one of the few digital registries at the time. They consolidated breast cancer services. They looked at screening and they said, we need to have research built in here. So that was great back in 1996, 97. So that was implemented then. And in implementing that, if you took breast cancer as an example, so I think you need to have indicators to show, and I'm just taking one example just in the interest of time. So if we look by 2006, we'd seen a change, a decrease in mortality by nearly 30% for breast cancer. By 2013, breast cancer in Northern Ireland had the highest survival rate in the United Kingdom. So there's an example of taking something, producing it, not putting it on the shelf, getting a task force together, implementing 4 things, key things. I'm not saying they're the only 4 things, but they were the most important 4 things at that moment in time for Northern Ireland. And just taking breast cancer as an example of how, that can improve over a relatively short time period, because they were changing like 30% is a huge difference now. Similarly, moving from being the worst to being the best was also a big difference. So that just gives you one example, but that touches some of the key points.
Any other? Yeah.
Yeah, I can add to that. I think, whilst there's a common structure to cancer plans generally, there's the risk factors, so detection, treatment, care, and then palliation, etc. The most important thing is if a government is encouraged to put together a national cancer control plan, they have to understand their burden or want to understand their burden in the future. And a core investment for all government should be in cancer registries in order to get the data, so that we understand what they're doing, what the problem is in the future, and they can build a long-term infrastructure to deal with that long-term problem. In order to do a plan, most governments, although it is the health minister that takes the lead, it engages other government departments. They have to, finance particularly, but also other departments, trade, industry, etc., etc. And I think that's good because it becomes a whole of government issue, a real whole of government issue. And it in itself, I think it signals to the general population that cancer, which will have been affecting people's lives and their grandmothers and things like that, can move from what it used to be in the 50s, 60s, 70s to the big C, something that's discussed and can be dealt with. And it gives hope to people who have experienced cancer because the government is taking it seriously. So I think we always push that there should be a national plan. always should be a national plan. You can't integrate it into the health system. The treatment of cancer is unique. It needs a tertiary care solution. It needs comprehensive cancer centres. Many countries have a National Cancer Institute, which conducts the research and the understanding of what's going on, coordinates the trials, etc., etc. It is a unique set of diseases that demands a unique solution and, by definition, a unique plan. So that's I think there's so many benefits from having a plan for the government, the people, the patients and others that it's really quite strange now when I hear that a government hasn't got a plan.
Yeah.
I don't know why.
Well, I suppose it's probably because they hadn't got a plan for most things in the last 14 years.
Maybe a common problem.
And what I would like to see now is a second generation of national cancer plans. I mean, I think we need to start being a bit more ambitious. So we believe that the next generation of national cancer plans should be more comprehensive. You mentioned, Kerry, that should be looking at risk factors, but prevention at all spectrum of prevention. For instance, in the previous panel, you spoke about AMR. So the infections, the plan should go beyond strictly cancer, should start looking, for instance, at so yes, we need to prevent cancer, but we also, once you get cancer, we need to do anything possible to prevent an infection. And then if an infection is there, we need to find ways, any way possible to treat the infection. Because, I mean, your data were very conservative. You mentioned 10% of cancer deaths are due to an infection. My data say 50%.
50%?
50%. We did recently a literature review.
Can you give me that data?
Yeah, I will. I will. It's beyond that, apparently in a few years, I mean, there are oncologists that fear that in a few years, due to AMR, the traditional cancer treatments like chemotherapy won't be a viable solution anymore. So we need, all these aspects should be embedded into the cancer plan, including in Europe, for instance, the possibility of cross-border care. I mean, this is also something that, we have a cross-border health care directive in Europe, but how well this is implemented, I mean, it's very badly implemented, but we need it. We need it for especially rarer cancers. So we need to make sure that all those aspects are included in the cancer plan.
I will say that one of the values of the National Cancer Control Plan is that it allows the government to lay down what the priorities are.
Yeah.
Because they have a funding envelope and that's it. You know, it's not like, here's the plan, cover everything from risk factors, AMR, all the way through and now do it all. We've got to be realistic. They've got to look at it and take some priority decisions. Is it disease priority, indication priority? Do they focus, I think yesterday, was it 4%? Someone said 4% is on prevention.
Yeah.
I mean, longer term, that's not a very good idea.
Yeah.
I mean, we've got to have more in managing the risk factors and reducing the burden of cancer coming through. So I think that National Cancer Control Plan, if you engage other stakeholders, you hopefully end up with a set of priorities, which are the best priorities for that particular country, given the circumstance they have and they foresee. So that's another value of the plan, I think.
Jennifer,
Yeah, I would echo that, Kerry, in terms of, essentially the NCCP is a roadmap for driving prioritization and in particular political prioritization, given that we know governments are balancing many different challenges, not just in the health space, but also, writ large, particularly when it comes to the purse and kind of deciding where they're spending their budget dollars. I think the other kind of important aspect is that the plans can evolve. And as you were saying, several of us were saying, are evaluated at regular intervals to ensure that they continue to be fit for purpose. And I think particularly now as we're in this era of artificial intelligence and, looking at other ways to integrate, more comprehensive data sets and frankly, facilitate more data and information sharing across borders, but also across academic and research institutions, NCCPs can really be sort of a convening point and really a compass in a way for driving kind of that sharing.
Any questions? We've got about 13 minutes left according to the clock. So any questions? Yes, over there.
I can't see anything.
No, it's impossible.
Thank you. Hello, Francesco Ghini from Italy, from IOST Cancer Hospital. Many thanks for your comments and your contribution. And I'm quite interested in this part of the National Cancer Control Plan. And I would like to propose to you also another point of view and asking for your comments that is related to the staff shortage we are actually facing, for example, in Italy. But I think it's something also quite common in all the European landscapes. So if on one end we are creating this advanced national cancer plan, on the other hand, we have no nurses, low numbers of physicians. So how we can keep these two things together? Thank you.
Good question.
Maybe I can start, and it continues the conversation we had last night at dinner. Very good question in terms of the cancer workforce. The European Cancer Organization has put out a report in relation to this just before Christmas. And I'm going to be perfectly frank here. We're not going to be able to reappoint ourselves out of the crisis we are in relation to the workforce. So we're never going to get back to the same levels that we were, I don't think, certainly not in the near future, because we have a big challenge in relation to the number of people who are trained, the number of people who have stepped away, partially due to COVID, the amount of people who have mental issues. You were saying in terms of anecdotally, 8 out of 10 of the people that you've talked to, are clinicians or have mental challenges associated with them. We've shown that 3 out of 10 have had aspects of breakdown, 4 out of 10 with nervous breakdown, 3 out of 10 with actual signs of clinical depression. So I think we're going to have to look at how do we combine the workforce with the use of digital. Because I think we can't just say we're going to reappoint everybody and everything's going to be fine again. So we need to look at clever ways in which certain things can be done through digital, certain things require the attention of the specialist nurse, specialist doctor, etc. We've done a study in relation to One London, which is an area of London, 10 million, 1,400 GP practices, 14 hospital trusts, linking them all together in what we're calling a digital London or a digital part of London. And what we've shown there is that one of the key things that digital can do is actually save time. So it can actually save time and remove the tasks that cancer specialists shouldn't be doing. And we came up earlier in one of the sessions in relation to spending so much time. I think it was in the palliative care session in terms of filling out notes and dealing with red tape. So that we're actually looking at devoting the cancer specialist time to the time that actually is their best time, because it's the time they use to actually talk to the patients. But I do think we're going to have to look at a different model in terms of the workforce, and that workforce is going to have to include a digital workforce.
Any other comments? I think really good question.
David Collingridge would be your friend. He's the editor of Oncology. He did a great presentation I saw last year about the lack of cancer healthcare workforce around the world, and that's the stark problem as he presented it in that presentation, that we've got to somehow increase the number of oncologists there are and pathologists and everything else. But what does good look like? So I recall many years ago, I was in Hong Kong. I went to meet the cancer registry there, and they had all great data. They'd really got good data. And I said, so what do you do with this data? And then they showed me a model that they were working on, which predicted the cancer burden over like a 20-year period, and the number of nurses, oncologists, radio-oncologists that they would need in order in the current technology and the model, how many they'd need in the future. And that was fed into the government, into the education department, in order for them to encourage medical students to take on the profession of oncology in the future, because they knew how many they would need. I thought that was really clever and neat, and I hadn't seen it anywhere else. And I don't know whether the UK does that or anyone else does it, but if you get that base data, the question is, how do you use it? Not just to say how many medicines you want, radiotherapy machines, but also the human challenge you have of getting medical students to go through and then come out and say, I want to do oncology. So it's still a choice, I believe, rather than being dictated.
Yeah. And I totally agree with both Mark and Kerry. I can only add that a good cancer control plan should also address resources, financial and human resources. So in order to make the plan implementable or viable, there should be financial and human resources allocated. And that will show the lack, even more probably, the lack of resources.
But we shouldn't see the solution as recruiting them from Africa, to be fair.
No.
And that happens a lot. And that is really sad because that's, as I said earlier, that's 70% of the burden.
Exactly, and taking away.
And it's going to grow. And we're taking the people who are skilled are being taken out.
Interesting. One of Steve Bryan, who's the chair of the Health and Social Care Committee in the UK, so he's a member of Parliament, and he came out and categorically said, and was made no bones about it, he said, when I was developing a plan in relation to cancer, I should have developed a workforce plan as well. So he's out as saying that. So again, it goes very back to what we're saying. That needs to be part of your overall plan. But I'm suggesting that it has to be a mixture of human, which we obviously need, but also digital. Otherwise, we're not going to get enough people to actually do the roles because of the challenge that COVID has presented to our overall workforce.
I'm comforted by the use of AI and remote now. I'm not a specialist in pathology, but when I hear that the Geneva Hospital for Cancer is doing remote pathology using AI for Mongolia, that really gives me comfort because it can be done.
Exactly.
There's always been an argument you can't get enough pathologists in low middle income countries to actually diagnose, to identify what the cancer is. But if we can apply AI remotely and get centers of excellence all around the world, then we have a less of a problem in terms of training up pathologists in the future. And that would be great.
Jennifer, is there anything you want to add to?
I agree with all the comments made, and I would say, I think it has to be a bit of a balance as well, because on the one hand, there's the opportunity to take advantage of really the technological and e-health platforms. I think on the other hand, we need to be careful that we're not unintentionally slowing down things because we don't have the capabilities at our fingertips at the local level because we just, it's more decentralized. So I think that's just something to keep in mind with respect to implementation of the plans.
Can I just build on saying that Antonella said about data and evidence, things like that? There was so Georgia Lane, who some of you may or may not have heard of, was a great advocate for NCDs and cancer over multiple years, still working out of Miami. But I remember sitting down with him once at the World Health Assembly. And I'm a banker by tradition background, and I thought, well, evidence and data, that's how you win the world. And he said, my dear sir, as if I was some sort of student, because he is a professor.
That's the way he would do it as well.
And those of you who know him, he's a charming, lovely man, Sir Georgia Lane. He said, in my opinion, you have to influence with the head, the heart, and the pocket. Okay, the three component parts of great advocacy that you do need the data, the head, but you have to appeal to the heart of politicians, and you have to make sure you understand the funding side of it as well. And in those three words, it sort of framed my thinking about advocacy when I first got into this world, that we have to do all three component parts. And the heart, the example of the patient story, these are things that can win over politicians who see the importance of a national cancer control plan, although it's mostly generated by data.
Well, interesting. So an example I shared at dinner last night. So metastatic colorectal cancer in England was essentially, there was a rule in England that if you went off treatment, for example, if your doctor suggested you need to go off treatment because of side effects, you couldn't get back on treatment again. So it was a big inequality for metastatic cancer, colorectal cancer patients. So we paired up with Bowel Cancer UK, which is one of the leading colorectal cancer charities in the UK, and looked at three aspects. So one, continuous versus intermittent, so all the time versus stopping and starting, giving treatment holidays to the patients. One, did it have any effect on survival, depending on what we did? So both had exactly the same survival. So there was no adverse effect in terms of not giving it all the time. Secondly, we had really good patient stories in relation to how we provided the information. And I agree with Kerry, it is really important. But in this situation, the key piece of evidence was actually that we would save the NHS 1.2 billion if they actually went with the approach that we were suggesting. And they did that. And now that inequality has been removed. It's a pity it took them 5 years to do it when we generated the data and the evidence inside too. But so unfortunately, sometimes I agree with you. So sometimes the head rules the heart, and other times the other way around. But that was a great example, though, of us working together, providing accumulated evidence that each said to the same thing. This is a stupid policy. This is an anti-patient policy. We need to change it.
Any other questions from the floor? Oh, yep, go ahead. Yep. This is going to have to be the last one, I suspect.
No pressure then. Thanks very much, James Hargrave from Daiichi Sankyo, based in the UK. I also chair a group called Keep Up With Cancer, which is a coalition of oncology companies in the UK. And then, as just been mentioned by Jennifer, we've been all making our submissions to the developing cancer plan for England. And I wondered if the panel has anything to say about how you strike the balance between a plan that is fixing the problems in the here and now, but whilst also trying to kind of project what a vision of the future you're trying to build. Because one of our concerns in England is that a plan may be so focused on trying to frankly put out the fires at the moment, you might not actually leave any sense of what you're trying to get to.
Great question. I was about to ask that one, actually. That's good.
Sorry.
No.
Excellent, James, and good to see you, James. Yeah, I mean, I think we need to do both. Fortunately, I think there are fires that we have to put out, and unfortunately, there's quite serious fires. But I think if we don't have ambition, then it goes back to what was said by Kerry, and it's really important. It has to be that consistency. So it can't be just, let's solve the problem now, and then we haven't thought at all about we're going to be in 5 years. So it has to be something that addresses something. And again, it goes back to what Kerry said. Unfortunately, the government will not take every recommendation, but we need to have that balance between how do you solve the here and now, how do you provide solutions, but also how are you ambitious in terms of thinking about where are we going to be in 2035 in 10 years' time.
Yeah. This is what I would call the second generation cancer control plans, because we do need this kind of vision embedded into the cancer plans now, because we do not want to stop the innovation. I mean, the innovation goes very fast. So the cancer plan should be as flexible as possible, embedding this sort of vision and changes that can happen in the near future. Because now it's not even that the innovation is the day after tomorrow, it's tomorrow or maybe today. So while also because the national cancer plans are not developed overnight. They take months or years to develop. Then by the time you have a cancer plan, the situation, the treatment situation might have changed. And there are some treatments that have a huge impact or are hugely impacted by the way the health care system is structured. I mean, let's think of CAR T-cell, for instance. It's a completely different concept of treatment, of delivering the treatment, of setting up the treatment. If this has not been embedded into the cancer plan, then how can the innovation be taken into consideration by the member states?
Yep.
So,
Kerry, and then our last word to Jennifer, and then we'll have to close up.
Can I have the last word?
no problem.
Sure.
That's okay.
No.
If I could have the last word.
Okay, of course, yeah.
Yeah, so I would just add that I think what you've highlighted is just really underscores why it's so important to have regular consultation with a range of stakeholders, providing inputs based on the data that we're seeing, sharing the information to ensure that we're not only tackling the problems of today, but also developing solutions that will be sustainable for into the future.
All right, last word.
I'm from Switzerland, so I'm allowed to go off-piste. Is that okay?
Certainly.
Excellent. I just wanted to say publicly a big thank you to the Economist Group, because last year there was an issue with regard to the Economist working with the tobacco industry. A lot of us became aware of that. I spoke to Vivek, I spoke to the CEO, and I know the board considered that. And I've got to say that we were absolutely delighted that the board of the Economist Group decided to exit all their relationships with tobacco. And that's why we're here today. So I would like to say thank you to the Economist Group on behalf of the cancer community for making that very, very great decision as far as we're concerned. And the fact that I'm enjoying this so much means that it's the right decision for me too. So perhaps we could give the Economist a round of applause.
Great. Well, let me without taking the last word, which I am now, but let me echo the thanks that all of you have supported us through the years and have supported us through that decision as well. So, we're very, very grateful to all of you. So thank you. So thank you. We'll round up the panel there. And this panel, thank you for our sponsors for this panel and indeed for the event, Pfizer. While you exit stage right or left, we're going to show a short video which speaks to this theme of improving diagnosis and treatment from Pfizer, actually. It's a couple of minutes. So thank you very much indeed.
Thank you.
Thanks. Thanks.
We've seen a shift in cancer care over the last few decades. More people are living with and beyond the disease. In Europe, around 5% of people had experienced cancer by 2020, and 38% of those had been living at least 10 years since their diagnosis. But survivorship isn't just about giving patients more time, it's about supporting them to live the best lives they can, and that's where many systems fall short. I'm Alicia White, a senior manager in the Health Policy and Insights team at Economist Impact. National cancer control plans lay out how health systems will tackle cancer, with the aim of reducing cases and deaths and improving patients' quality of life. However, only around half of global cancer plans include strategies for survivorship care and for rehabilitation once treatment ends. Fewer than 1 in 5 of the plans included direct input from cancer survivors when they were developed. And in most cases, the public weren't invited to review or comment on these plans that could shape their lives. That matters, because support networks, emotional well-being, financial strain, and long-term health effects aren't side issues. They're central to the experience of living with and beyond cancer. Through Economist Impact's research, we have developed the North Star framework to help governments and organizations embed holistic measures of survivorship into the core of their cancer strategies. The framework encourages support and care that is integrated, person-centered, and designed to help improve the outcomes that matter to those affected. We're beginning to see shifts towards greater focus on survivorship, but the work is far from over. Redefining success in cancer care means looking beyond solely survival to meeting people's long-term physical, mental, social, and emotional needs. That begins by placing the patient at the center of every country's cancer plan.